Immediate implant placement is a hot topic in today's clinical practice. Let's discuss now how to approach this clinical situation between art and science. Sites of implant placement can be classified according to the timing. This classification from Hammerle is widely diffused and it distinguished between type 1 or immediate post-extraction implants, type 2 when the implant is placed between 4 and 8 weeks from tooth extraction, type 3 when the implant is placed after 12-16 weeks from tooth extraction, and type 4 when the implant is placed beyond 16 weeks from tooth extraction. But very useful in clinical practice is an old classification from Wilson and Weber that classified site of implant placement between immediate site when the implant is placed immediately after tooth extraction, recent sites after 4-8 weeks, delayed site when the site is prepared through socket preservation or pre-implant regeneration, then mature sites when the clinician has to place an implant in a ridge where the tooth was extracted long time ago. Since the late 90s and the following decade, we know from literature that survival rate of immediate post-extraction implants are very positive. And equally, we know from literature that clinical and radiographic results are comparable between immediate, delayed, or late implants. Several systematic reviews has been done on immediate post-extraction implants. Controversies are still present about aesthetic performance of immediate post-extraction implants. Many of the following considerations have been derived from our textbook published in 2003 about immediate post-extraction implants. We have to take in consideration the differences between the periodontal environment and the peri-implant environment when we pass from a situation to another. At tooth extraction, in some months, the socket heals, filling with bone, but reducing its volume both in age and in horizontal width. When we take out a tooth and we place an implant in the post-extraction socket, we usually have a void, a gap between bone and implant. A gap that usually fills of bone both horizontally and vertically. Both Wilson and co-workers and Paolo Antonio and co-workers demonstrated that such a gap can fill spontaneously when its dimension is under 2 millimeters. And Cornellini and co-workers demonstrated that GBR can be performed around an immediate post-extraction implant left to heal non-submerged. Then several animal studies and a couple of human studies from the group of Gothenburg showed that the immediate post-extraction implants are at risk of gingival recession due to the reduction of the horizontal width of the ridge after tooth extraction, irrespective to the positioning of an implant. But let's see what we know actually about immediate post-extraction implants. 3 papers from the group of Chen gave us valuable information on such a procedure. In a first randomized prospective study, in which 30 single implants were placed immediately at tooth extraction, 10 of them had their buccal gap filled with anorganic bovine bone particles, 10 treated with the same biomaterial plus a collagen membrane, and 10 were not grafted. The implants were followed up for 4 years, and the horizontal resorption was significantly reduced in the 2 groups with the gap filled by biomaterials. The reduction with only bovine bone in the gap was 1/3, almost 1/3 that the control group. Recessions occurred in 33.3% of the sites at 6 months, with 26.7% of anesthetic results. But such negative results were associated with a buccal placement of the implant compared to the implants that were palatally placed and in which the gap was more than 2 millimeters. Significant was the difference. Between 6 months and 4 years, the gingival margin can be considered stable during time. In a second paper, a retrospective study on 42 patients, all treated in the frontal area with immediate implants, the recession was 0.9 millimeters from 1.8 on implants placed buccally to 0.6 on implants palatally placed. The difference was highly significant. In a following retrospective study on 85 patients, 85 upper incisors were placed as single immediate implants with a FLAPLESS procedure. The recession at time of restoration was calculated almost at 0.4 millimeters, again with buccal implant with a significant negative difference compared to palatal placed implant. A recession at restoration of almost 0.9 millimeters was present in 24% of the thin biotypes, while only in 10.5% of thick biotypes. During the almost 2-year follow-up, the recession was stable during time, and it was estimated in 0.02 millimeters. In 100% of the cases with an initial probing depth equal or more than 4 millimeters, a recession occurred at time of restoration. So we learned from those papers that we can have a certain amount of recession, but this risk is minimum when the biotype is thick, when the implant is properly palatally placed, and the gap is filled on the buccal aspect, and the buccal plate is still present without a probing depth on the fascial aspect. In 2010, the European Academy for Osseointegration Research Prize was assigned to a randomized controlled trial on immediate versus delayed implant in anterior teeth. This paper from Maurizio Tonetti and co-workers, in which I participated too as a surgeon, with randomization after tooth extraction, some implants were placed immediately after tooth extraction and some after 12 weeks. At restoration, then during follow-up, measurements were taken from a clinical and radiographic point of view and by means of impressions to better evaluate the horizontal modification of the tissue volumes. Having a look at surgical outcomes, less problems were encountered with delayed implants, and evaluating the results according to the pink aesthetic score, an objective system to measure the aesthetic value of a procedure, better results for delayed implant compared to those of immediate ones. But we have to focus on a critical aspect, that the two surgical methods compared in such a research where the best technique ever used is the state-of-the-art procedure for delayed implants, but an old approach for what concerns immediate implants, because in all the cases papilla were cut and elevated, and not a flapless procedure was the gold standard of such a surgical treatment. Therefore, let's see what is crucial for achieving optimal aesthetic results on immediate implants. Conventional consideration of three-dimensional implant positioning in the aesthetic zone have to be kept in mind when placing an immediate implant, especially to leave 2 millimeters at least between the implant shoulder and the neighboring root in order to allow the presence of a papilla 5 millimeters from top of the crest to the contact point. Such an horizontal dimension is the minimum to allow a proper vascularity to maintain the papilla in place, as Choquet demonstrated. We know that a crestal bone resorption occurs starting from the implant abutment connection, and we use to imagine that is a bidimensional phenomenon, but such an aspect occurs three-dimensionally. Therefore, we have to move palatally the implant in order to have the implant abutment connection far from the buccal aspect of the bone crest. Then the gingival thickness has to be considered. A thick gingiva allows for biological width repositioning without consistent bone remodeling. So the gingival biotype is very important, and it has to be thick to have optimal aesthetic results on immediate implants. As it was said, the implant has to be placed palatally in order to move the gap between implant and abutment far from the buccal aspect to maintain bone underneath the gingival tissue, avoiding a recession. Let's see in this case the gold standard of the immediate implant placement, an external root resorption on the upper left central incisor. The tooth is removed and an osteotomy is drilled on the palatal aspect of the socket. Therefore, a new surgical socket is created and the implant placed inside an ideal line surrounding the buccal aspects of all neighboring teeth. The buccal gap is filled with biomaterials. and then some collagen is placed on top. The pontic is able to maintain soft tissue contour, and when the implant is loaded at the time of osseointegration, no recession, no major modification of the hard and soft tissues occur around the immediately placed implant. Very different the result when we place the implant the same way. We do not fill the gap. Maybe we cannot face our gingival recession, but we have a huge reduction in the horizontal width. And to place a wider implant, like we did at the beginning 20 years ago, can develop a recession by itself. And if the result around of such a facial implant is not so bad, is every time in recession compared to the reference contralateral tooth. It's really important to probe the buccal aspect of the tooth that has to be extracted, because a probing depth of more than 4 millimeters, as Chen demonstrated, probably corresponds to a loss of the buccal bone plate. In those cases, a socket preservation procedure extracted the tooth with a flapless procedure, then placing biomaterials in the socket and some collagen on top, and using again the pontic to maintain the soft tissue profile, allows for some months of bone healing, then to place an implant in a proper aesthetic position and to restore it with nice results. But when we have a thick biotype, an intact bone wall on the buccal, like in this case with a horizontal fracture, as soon as the tooth is extracted, a new socket is surgically prepared, the implant is placed, the gap filled, some collagen on top, the crown is separated from the root and bonded to the neighboring teeth, and here how the patient goes out from the office, here at 1 week, then at 6 months, 1 year, 3 years, and 6 years from the restoration, with very stable results with this ideal initial condition. Let's see now which is the prognosis of immediate post-extraction implants immediately loaded at implant insertion. A systematic review from Strobe shows high results in mandible and wider variability for the maxilla, but only 2 studies are on partial edentulous. Some key factors are underscored by the author: patient selection, primary stability, and surgeon's experience in order to have best results with this procedure. Remember that this is where we started. The first paper that analyzed immediate loading both in immediately placed and in delayed placed implants demonstrated very high risk of failure for immediately placed, immediately loaded implant. That was, of course, related with the minor primary stability got with immediately placed implants. A recent systematic review about immediately placed implants demonstrated equal survival rate between immediate loaded and conventionally loaded implants, of course, with a careful selection of the patient. We know that osseointegration can take place in absence of micromotion, and this condition is easy to be found when multiple implants can be splinted together by the restoration. Such an absence of micromotion is more difficult when we have to immediately restore an immediate implant. Therefore, it's not a problem if we have several gaps around immediately placed implants when we can splint them together with a fixed restoration. But dealing with single implants with careful case selection, nice clinical results in terms of survival rate for this approach. Also in those papers with at least 5 years of follow-up. What about aesthetics on single implants immediately placed and immediately restored? Joseph Chen demonstrated that we can get good results also in this clinical situation. A randomized control study on pink aesthetic score or aesthetic results of immediately loaded implants comparing implant immediately placed and implant placed in areas where a socket preservation procedure was performed some months before. Comparable results for the two procedures. Some authors claimed of the possibility of improving the biotype, the thickness of the buccal soft tissue, by placing a connective tissue graft at the time of implant placement. And some papers demonstrated that such thickness can be improved also on immediately placed, immediately loaded implants. Therefore, with a more difficult procedure, we can treat all those risky situations like an infection and a recession on a tooth that has to be extracted for a vertical fracture and then an odontic failure. The flap can be designed according to the principles of the periodontal plastic surgery to advance the buccal soft tissue. The tooth can be taken out and the socket cleaned and the implant placed in the proper aesthetic position. Then the regenerative procedure performed and a screw-retained temporary crown can be placed on top of the implant. Here the healing at 2 weeks, no more fistula. And this is the result at the end of treatment compared to the initial situation. And here the cam beam CT scan at 6 months at time of placement of the definitive restoration. A systematic review by Cousin demonstrated that when we have intact buccal bone plate and thick gingival biotype, and we can perform flapless surgery and we can place an immediate restoration, there is a limited risk, less than 10%, of severe buccal gingival recession more than 1 millimeter. And from the look we can focus on some diagnostic key factors: the gingival biotype, the intact buccal bone plate, and the available apical bone. We need to have a strong primary stability when we need to restore immediately the immediately placed implant. And surgical key factors can be considered the following: flapless surgery, adequate three-dimensional implant positioning, primary stability, and filling the buccal gap. Then, from a restorative point of view, the emergence profile with very low pressure on the buccal can allow for optimal aesthetic results too. Let's see this case in which a small amount of recession for the buccal migration of the unrestorable tooth was present. the tooth is taken out, the implant immediately placed, then the temporary crown is placed, and allowing space on the buccal for the gingiva, the recession is compensated by the coronal growth of the gingival margin. But absolutely the most important key factor when we have to restore immediately an implant placed in a fresh extraction socket is to get proper primary stability. And in order to achieve such optimal primary stability, the implant design will be very helpful. Very different will be the primary stability achieved only in this apical portion when a tapered implant is inserted instead of a cylindrical one. At an equal vertical extent of primary bone-to-implant contact, the tapered implant will achieve by far a superior insertion torque due to its conical coupling with bone, therefore fulfilling at best the clinician's expectation in those challenging cases.